Great. Well, I want to welcome everyone to a fireside chat with the Black Scientists Taskforce on vaccine equity. The task force was created in partnership with Taibu Community Health Center to address Black community concerns and issues related to the COVID-19 pandemic, testing, and vaccines. And it's one of the approaches that we're using to communicate, mobilize, and engage Black communities most affected by the pandemic in order to address systemic inequities. So we are really excited for this fireside chat, which is co-sponsored by the Black Gay Men's Network of Ontario, the Regional HIV AIDS Connection, and Gay Men's Sexual Health Network. So we are going to be speaking specifically to issues affecting Black LGBTQ communities in Ontario and the Greater Toronto Area. And we're also going to be speaking, of course, more generally to Black communities in Ontario. This should be a really interesting session because we're going to be dealing with lots of intersectional issues, of course, around sexuality and gender and immigration and class and housing and neighborhoods. So we're really excited for an engaging conversation. And we really encourage you to be interactive and to put questions in the Q&A window. And we will answer those questions, the panel will answer those questions in the second part of the presentation. So now I want to introduce I'm serving as the moderator, but for an introduction to the task force and to give a libation, I want to introduce Dr. Akwatu Kenti.
Thank you very much, Lance. And it's a pleasure to be here. And first of all, I want to acknowledge that we are on the grounds of Takaronto, home to many Indigenous people, First Nations, Métis, Inuit, and that colonization hasn't gone away. So that the acknowledgement of this land really is baby steps towards the co-creation of a new culture of respect for not just for the land, but for the Indigenous people who have lived here since time immemorial. I always also think it's very important to ground our conversations in the Black experience, the experience of people of African descent who were kidnapped from Africa and brought here, as well as those who have recently arrived as immigrants and migrants and refugees. We know that infectious disease is not new to humanity. And we know that African people in various parts of the continent, west, north, east, and south, actually recognized infectious diseases, referring to them all in different ways, but translated loosely as illnesses of the wind, things that you can communicate by breathing dust carried from one person to the next. And different groups, especially Bantu speakers, have been found to have this concept. Most importantly, however, we also had the concept of inoculation. And I like to start the conversation in terms of a libation by acknowledging the African man, Onesimus, mistakenly, erroneously, and deliberately misnamed Onesimus. His African name could probably have been Kwame because he came from the Akan-speaking region of Ghana, West Africa. And Onesimus was in Boston in 1721. He was brought here in 1716, sold to a priest named Cotton Mather. 1721 in Boston, they had a smallpox outbreak. And everybody was in a panic because death was certain for many people. And Onesimus said, I don't have to worry. And Cotton said, why don't you have to worry? He said, well, because when I was a child, we had a similar outbreak and our healer went around the village, he took the pus from somebody who was sick and went around the village sticking everybody. And in that way, we became protected. And Cotton Mather didn't believe him. So he actually went and interrogated other Africans from West Africa. And when he heard the same story, he hooked up with a guy named Boylston and they did a test. and then they wanted to do the same thing in Boston, and people were vaccine hesitant back then. So 300 years ago, vaccine hesitant meant that the people of Boston, the white people of Boston, were refusing to be inoculated, or with a technical variolation, because they thought of it as a pagan African tradition associated with evil beliefs. There's the historical irony of how the tables have turned and things have changed. But I ground the conversation that we're about to have in the lived experience of Onesimus, who was a culture bearer. He didn't come here as an empty vessel. He wasn't brought here as an empty vessel. And it's very important to understand and appreciate that there was no empty vessels on any of those ships coming across from Africa. So I leave it with Onesimus, who actually didn't get any profits, copyright, or benefits from having introduced this concept to North America. Very important. So we are very blessed to have as our moderator, Dr. Lance McCready, a nationally recognized researcher, lecturer, author, and systems thinker in the area of youth, young adulthood, urban culture, and development, touching on a wide variety of areas from employment and education to the health of urban youth, Black and LGBTQ+ youth. He's an associate professor in the Department of Leadership, Higher and Adult Education at UFT, and gained his doctoral degree from UCLA Berkeley, a very well-known institution. And so pleased and privileged to be here with you, Dr. McCready, but I won't call you Lance. I got accustomed to call you Lance. So I just to keep it informal, you have a PowerPoint, but I just want to make about 6 or 7 key points by way of context. And then I'm going to turn it over to Lance to introduce the task force members who will be answering your questions and taking it from there. A couple of points that I think is very important to make. One is, we've never had a Black Scientists Taskforce on vaccine equity in Canada before. It's unprecedented. Usually we hear from experts from other communities advising the government, advise on various media, talking about some of these issues. But this is the first time really we've actually gathered experts on a topic of priority concern to our people during a time of crisis. And those experts are from Africa, from the Caribbean, they're of African descent from Europe. We've tried to cover the bases globally as well as culturally, and it's challenging, but we've succeeded, and I think it's a model for the future on all the challenges that we face as a people here in North America. So that's very important, and I feel very privileged to be part of it and to be of service during the pandemic with these people who really are some of the brightest minds that we have. That's the point number one. Point number two, we've gotten some of the key questions that people registered with. And I think it's important to note at the outset that the City of Toronto has really recognized anti-Black racism as an issue, and they have a confronting anti-Black racism unit. They've recognized the disparities that have occurred with Black, racialized, and other communities around COVID. They have an equity initiative that's addressing mental health needs, material needs, well-being, transportation needs, testing, and they're making a significant and probably unprecedented effort to address some of the COVID inequities. It isn't thorough and complete because of limitations of resources, but it is significant. Nevertheless, there are significant alignments between the city, the province, and the feds, but there's also significant areas of gaps or misalignments. I think there's alignment between the city, the province, and the feds on the need to reduce positivity and hospitalization. I think we align on the need to effectively reduce vaccine hesitancy through public education. And we are also aligned on the need to build herd immunity through mass immunization. We are not aligned on the social determinants of health, issues related to income, sick leave, and housing. Critical to sort of really put a stop to the spread of COVID-19. We're not aligned on health equity. especially the racialized risks due to the joint collusion, I would say, of systemic racism and employment. And we are not aligned on an all-of-government approach to the pandemic and strategies to immunize the entire population according to risk. And I know that I've seen many of the questions, and I know that I just wanted to say it to sort of set the context. It's a public health crisis for Canada at large, for North America, for the whole world, an unprecedented one in 100 years. But it's a catastrophe for people of African descent who live in post-slavery societies. I say post-slavery societies because it's notable that many African countries are doing very well in managing COVID-19 through public health measures, because most don't have the access to the vaccine. Some of the Caribbean countries were also started off doing very well. But Black minority groups, when I say Black minority groups, I don't mean population-wise, I mean power-wise. Black populations in Brazil, in Colombia, in America, in Canada, in the UK, in France, we are all suffering disproportionately from COVID-19. We have greater rates of hospitalization. And when we get hospitalized, in Toronto, it's 9% of the population, 25% of the hospitalized. We have greater rates of mortality. And we actually don't know for sure what the rates of mortality are in Toronto, but Stats Canada about a month ago published the results of a national study, which said that the white mortality rate from COVID was 16 per 100,000, and the Black mortality rate was 35 per 100,000, which is not at the same scale as our African-American brothers and sisters, but are similar in terms of proportion. We are dying at twice the rate of our fellow white Canadians, and which is what happens in America. We don't have data around people with HIV or LGBTQ+ who are Black. That intersectional piece hasn't been captured in the data. But I looked around and I found out that in England, in the UK, there is data. And what they're saying is that Black people who identified as LGBTQ+ were four times more likely with HIV, were 4 times more likely than Black people without HIV to die. And that once in hospital, some Blacks were 7 times more likely to die than non-Blacks. That's from the UK, suggesting that the mortality disparities are even huger. Of course, we've experienced a greater health burden from COVID, but we've also experienced a greater economic impact from COVID. More lost jobs, lost homes, lots of people evicted. Many of our women, Jamaican women, Nigerian women, who are the healthcare workers, who usually have to juggle 3 jobs at $14 an hour, found themselves with 1 job at $14 an hour and are struggling. And those are the people for whom they've had to turn to food banks and are getting support from the city. And we have too many of those. And of course, we know that globally, people involved in the sex trade have, because of social distancing rules, have lost the opportunity to make a living. And so for us, it's not a moral question, it's a human rights question. People in the sex trade should be able to access all of the financial benefits and social protections afforded to everyone in the countries affected by COVID. And that also includes emergency housing to those who are homeless, a moratorium on evictions, and assistance with rent or mortgage repayments for those who have lost their sources of income. I could talk about the mental health effects and the fact that as a race, or people, and I put quotation marks around race, we had a lot of pre-existing conditions going in, a lot of risk factors from the Black experience, living the Black experience. And COVID has magnified them all, from mental health to substance abuse, even to schizophrenia. And we could talk about that in some of the Q&A. And Yeah, I think the hope lies in that people are stepping forward and coming to realize how great this challenge is. And communities are stepping up, raising money to support members who have lost their jobs, lost their income. So we are not just watching the crisis unfold and not taking action. People are taking action all over Toronto. And I know that this community is also taking action. And some of the questions imply that you want to take further actions, and hopefully we'll provide answers that can allow you to sort of forge a strategy for moving ahead. All right, Lance, that's my contextual intro, and I'm going to turn it over to you.
Okay. And I thank you so much. And I think that your comments really reflect the way that this viruses and sort of information and the concerns are really moving, and changing every day, right? And I also want to, I appreciate you doing the land acknowledgement and our sort of virtual libations. I also want to mention that even the fact that we're using Zoom, that we should acknowledge that the headquarters of Zoom is in San Jose, and that was the territory once stewarded by the Mukwekma people in California. So that we have to really give thanks and acknowledge the way that they've stewarded that land, because that is what's allowing us to speak today via Zoom as well. And I love that you're, I'm in the Adult Education and Community Development Program at University of Toronto. So I love that we're doing a little community education to foster our lifelong learning along with everything else. So this is very exciting. Okay, I want to do introductions to our esteemed panel right now. And I'm going to start with, well, you didn't really introduce yourself, Kwatu, but Dr. Kwatu Kenti is the special advisor for the City of Toronto's Targeted COVID Equity Action Plan and the chair of the Black Scientists Taskforce. He's an assistant professor at the Dalla Lana School of Public Health, where he also serves as the special advisor on equity, inclusion, and affiliate scientist with the Center for Addiction and Mental Health. Then I want to introduce Dr. David Bert. Dr. Bert's an immunologist with more than 30 years of international experience in the research and development of vaccines against infectious diseases, including influenza and SARS. He holds a PhD in immunology from the University of Birmingham and a Bachelor of Science from the Biological Chemistry from Essex University. Next, I'd like to introduce Trevor Aldridge, who is the Senior Director of Quality and Compliance at Brevitas Consulting. He has more than 30 years of experience in the industry, including product and process development, manufacturing of biopharmaceuticals. Ooh, we got a lot to talk about there, that manufacturing. His previous positions include Director of Quality Operations with Sanofi Pasteur Ltd. And the Drug and Biological Specialist with Health Canada. So welcome to both of you. Then I'd like to introduce Dr. Candice Todd. Dr. Todd is a naturopathic doctor with expertise in health promotion and disease prevention. Dr. Todd completed her honors and Bachelor of Health Sciences degree at the University of Western Ontario. And I know there are many people in our LGBTQ communities who are interested in naturopathic and how to address issues of health sort of outside some of the more formal medical industry. And then I'd also really excited to introduce Selena Cesar Chavan, who has a Bachelor of Science and is the Executive MBA from the University of Toronto, as well as an MBA in Healthcare Management from the University of Phoenix. Although most noted for her service as a member of parliament with the government of Canada, representing the town of Whitby, Mrs. Cesar-Chavannes is also a renowned research consultant and has worked with a variety of international and Canadian private government and non-government organizations. And I know your book was recently released, and that's very exciting. And I encourage everybody to go out and get that. So thank you all very much for taking time this afternoon. So in the spirit of adult education, maybe, we could start this Q&A with just a basic question around vaccines and how they work. Now, I think, a couple of weeks ago, I think a lot of the conversation with African, Caribbean, Black communities focused on vaccine hesitancy. And I think in some ways, in some places in the media, it was almost as if the reason why there was some documentation of vaccine hesitancy in Black communities was because Black people didn't really understand the vaccine. I think that we've now moved to have to address much more that this isn't a knowledge issue in terms of the vaccine rollout. It's really an equity issue that's tied in with a number of different sort of statuses and stigma. But I still think it's sort of really interesting and a great place for us to start with, in general, some discussion about how vaccines work, how they provide us with immunity, whether they're safe for people with pre-existing health conditions like asthma or heart conditions. So who would like to start us out, sort of just giving us a little information about that?
I can start with that. Okay, thanks, Dr. Lance. It's good to be here with you guys. And yes, vaccines. Actually, vaccines work because we have an immune system. And this is a sort of fascinating system within our bodies that is there to fight anything that is foreign, that tries to enter our bodies, tries to hijack our bodies, tries to infect us. And vaccines actually vaccines actually produce an antigen. So they give something foreign to our bodies. Our immune system recognizes this item, and it could be, for instance, a virus, like the virus that causes COVID-19. Our immune system recognizes this as being foreign and makes antibodies that tries to prevent the virus from infecting our cells. We also have T cells. And after the infection has been controlled, our immune system has a memory, so that when that same virus comes along later on, our immune cells say, well, I recognize you, and they mount an even more vigorous response. Now, in the case of vaccines provide the immune system with a non-infectious part of the pathogen, like the virus. And in the case of the vaccines for COVID-19, this is a piece of the virus called the S protein, which is like the key that enables the virus to get into the cell. It unlocks the door to the cell and then starts to infect. So what the vaccines do is to provide us, our immune system, with information about that key. We make antibodies and T cells against it. We memorize it. And when the real virus that causes COVID comes along, we mount a vigorous response against the virus itself, which is now an infectious virus, but it's expressing that same key on its surface. And that's where we get our immunity against viruses like the one that causes COVID-19.
Thank you for that. Always interesting and taking me back to school, learning how, the virus and the vaccine, how that works. And Dr. Todd, is there any sort of naturopathic context that you like to add to that? I mean, I think a lot of people, there was a lot of, wondering whether even the history of vaccines and how they've been developed in the context of North America, is there some anti-Black racism that was involved in some of the development of some of those vaccines? Or I'm wondering what you could tell us about that too.
Sure. So as Dr. Bert mentioned, vaccines work with your immune system, and creating an immune system that is as resilient as it can possibly be is going to help you in creating that immune response against the virus. So from my perspective, doing all the things that you can do to support your immune health, which includes eating nutritious, nutrient-dense meals, getting out in the sun. We know that vitamin D deficiency is one of those things that can potentially lead you to poor outcomes if you do get COVID-19. Making sure that you are sleeping, so sleep and anti-stress types of things that you can incorporate into your day-to-day are all things that are going to help to keep the immune system more resilient. Exercise is another one of those things, drinking your water. So all of those sort of lifestyle things that we can do to keep our bodies resilient and also prevent some of the underlying conditions that we know that if you do get COVID, you'll have poorer outcomes with. So preventing things like diabetes and other metabolic diseases, preventing cardiovascular disease. And yeah, I'd say that. In terms of the historical background, definitely there are a number of reasons that Black people are, hesitant to get this vaccine historically. And I think Selena maybe can touch on that a little bit more.
So for sure, when we think about the historical context of Tuskegee, Henrietta Lacks, individuals who have contributed without their consent to any type of medication or experimentation, clinical trials or research. That has happened. That has a long legacy within our Black communities, and we know that that people know about them, and they've continued. The challenge right now is that the hesitancy is built upon those historical facts, but also present day racism that exists, or anti-Black racism that exists within our medical system. And somebody just put in the chat, why should I trust the vaccine? And that's a legitimate question. When we think about the fact that you present at hospital, you present within your healthcare system, and you're still experiencing racism, you're not getting the care that you need. And then all of a sudden people are saying, well, go get the vaccine, go get the vaccine. It's like, well, you didn't care about me yesterday, and all of a sudden you want to care about me so I could get a vaccine. So there is that. In the contents of this particular conversation, Dr. Akwatu Kenti talked about women, and the women in our community that are on the front lines that are experiencing sickness and death at higher rates. When we look at the context of this conversation around HIV AIDS, 50% of new diagnoses of HIV AIDS are among Black, Caribbean, and African women, right? If that was any other group, there would be a national outcry. 44% of new incidents of HIV with Indigenous women. We really have to think about the context of why this hesitancy has built up and has been sustained. There's a mistrust in the system, and we understand that. I think what we're here to do today is to ensure that people have the information that they need. Dr. Bert gave a really eloquent dissertation on how vaccines work. We want to make sure people are given that consent. What was missing from Tuskegee, what was missing from Henrietta Lacks, what is missing from some of those historical wrongdoings was the informed consent, the information that was required for people to make a decision that allows them to say, yes, I want to get vaccinated, or no, I still don't. We are hoping to give people the information that they need, understanding quite well that there is anti-Black racism that exists within the system. There's a lot of stigma. We understand that, but also to give you the information that you need, knowing that there are very esteemed people on this panel, much more than myself, to say, okay, here's the information that you could take for yourself to consent to taking the vaccine.
Yeah, you know, I thank you so much for that, because, you know, I have a good friend that basically told me, you know, Lance, I don't know, I'm just gonna wait. I'm gonna wait and get the vaccine because we don't really know what it's gonna do, right? So not even what the history, we don't know. And I think that raises a lot of questions I know that I even had, because there wasn't a lot in the media about who actually went through the clinical trials. For some folks, it happened, you know, quite quickly. So I'm wondering, I mean, do we know anything about the demographics of who participated in the clinical trials? Were Black people even a part of those clinical trials, so that we even know something about that, how the sort of the virus, I mean, how the vaccines have sort of worked maybe long-term in Black populations? I wonder if anybody. Oh, Dr. Aldridge.
I can talk about that a little bit.
Yeah.
So when we say long-term, you know, we have to be very careful there because we don't really have a lot of very long-term data, but long enough to give you a pretty good sense of appreciation of what the picture looks like. So to begin with, let me just talk a little bit about, you know, so you have to demonstrate the safety and efficacy of the vaccines, and that's a whole story to get into. But just strictly talking about the clinical trials that were done to evaluate the safety and efficacy, looking at the safety of the vaccine, looking at the clinical studies that were done, let's say, for example, the case of Pfizer. Pfizer study, they had a phase 2-3 study, that's a clinical study, referred to as a phase 2-3 study. And the criteria for inclusion in this study was adults 16 years of age or older, who are medically stable, were eligible for inclusion, and that included people who had HIV, who have had HIV, hepatitis B, hepatitis C, and you know other infection, other diseases. The study included roughly 43,000 participants, and of the 43,000, 83% were white, 9% were Black or African American, and about 28% were Hispanic or Latinx, as they refer to it. And some were obese, at 20% obese, and 21% had pre-existing conditions. Now, I don't know what the exact breakdown is of what those pre-existing conditions were, or if in fact anyone specifically with HIV was included, but the inclusion criteria included those people. So it is possible that those people are part of the study. So that just gives you a little bit of an idea of what the participants could look like in the study. Similarly, for Moderna, their study had included about 30,000 participants in a phase 3 study. And this study had 79% white among the participants, 10.2% Black or African American, and 20.5% Hispanic or Latino, as they refer to it. So again, a similar kind of profile for the study participants. So even, I mean, you could say that maybe more representation of some of the other groups besides the white population might have been more helpful. But anyway, there were participation of other folks in the studies. So at least we have that we can refer to. And in terms of the detailed breakdown, we could certainly get that information at some point. The end result of all of that was that basically there were no significant differences among those various populations that were studied, and the vaccine were determined to be safe and efficacious for the people included in that study. So that just gives you a quick summary of what the participants in the studies to establish those two vaccines in particular, what it looks like. So that covers that point.
I mean, I'm wondering, do you think it's relevant to even report the demographics of who is in those phase 3 clinical trials. I mean, I think part of the issue too is that even with so much of the media, oftentimes Black people don't even see themselves reflected in the fact that sort of the vaccines are being developed, or, you know, it's just talked about in such a general way. And I think that sometimes can contribute then to sort of many Black people thinking like, well, what is specifically, how did this impact, you know, Black people, or were Black people even involved? Yeah.
Well, maybe I can just jump in here, because I know normally in clinical trials, there isn't a good representation of Black people generally. Even in these trials for the COVID vaccines, I mean, there had to be a lot of efforts to try and recruit Black people. And to your question, yes, it's important to say and to advertise that Black people, we are participating in the trials, and we need to participate in the trials so that we can have data that reflects on how these medicines, these drugs, these vaccines are affecting us. So it's important. And just one thing, another interest for this particular panel is what about people with HIV? And they were included, but only after a lot of lobbying, because initially the Pfizer and Moderna trials excluded people with HIV. They were excluded. So there was a lot of lobbying that took place. And eventually, I think out of the 40,000 or so people that were in the Pfizer trial, they recruited 120 HIV positive individuals. And the Moderna trial recruited 176. This is just a very small amount out of the 40,000. And still we're waiting for data. Some of the trials have said there's no significant safety issues because these individuals were taking their medication, but you know, those numbers are so small, and it reminds you that, you know, sometimes you have to really lobby these organizations and these companies to make sure that you're represented.
Yeah, and I guess another point, you know, that we could make is that maybe this will sort of give a little bit more impetus for people to participate in future trials, because certainly, and you know, certainly in one of the things that we can talk about is there's a question about HIV vaccines, but when we get to that point, we can talk about it. But there's certainly going to be an immense opportunity for people to participate in some of the trials coming up, future vaccines.
Can I just add before we go ahead? I think they're just in terms of this clinical trial versus average clinical trials. You know, Dr. Aldridge mentioned that the number is 9% for the Pfizer trial and 10% Black for the Moderna trial. On average, usually clinical trials only have about 5% of Black individuals. So I mean, those numbers are low, and we say, you know, contextually, if like, for example, a population like the United States or Canada has the United States has a large percentage of Black individuals, over 13%, then there should be a higher number. But when we think about the medications that we've been taking on a regular basis, their clinical trials on average have 5% Black individuals. So the recruitment effort, the amount of people that were in these particular trials are in fact double what we see on average.
Yeah, and just to add one more thing, you know, certainly it's ideal to have as many participants of groups that you particularly want to have included in the trial for the drug that you're studying. And I know Moderna had to delay their clinical trials significantly in order to get even that amount of participation in, so that we could actually have a vaccine at this point in time.
Yeah. Well, you know, since we are talking a little bit, I'll just sort of jump around a little bit, and we can sometimes talk about more specifically about some of the science and effectiveness of vaccines. And then sometimes I think we're going to talk about the just a lot of the equity, social inequalities that are sort of impacting sort of access to vaccines, et cetera. But one of the questions that has come up quite a lot is the effectiveness of vaccines with people living with HIV. and AIDS. So, and what do we know about that? So I guess we know that there were some PLHAs, people living with HIV and AIDS, that were involved in the vaccine trials. But I think you were saying, Dr. Bert, that we're still waiting on some of that sort of data so that we know. So is there even enough for us to know at this point, sort of the effectiveness of the vaccines with people living with HIV and AIDS?
But the only data that's out there, I mean, it's very vague, but for instance, AstraZeneca said, as far as they know at this stage, there have been no safety issues concerning HIV positive individuals. Novavax, which is another vaccine that's probably going to be the next one to be authorized in North America and Europe. They had 6% of the child population who were HIV individuals, and they haven't got any data yet. Moderna said that out of their 176 HIV positive participants, one who received the placebo and 0 who received the vaccine developed symptoms of COVID-19. So these are sort of, the numbers are so small, you can't really make any head or tail of what's been going on. And I think I've got a feeling that separate trials will have to be done with larger numbers of HIV individuals to really get a handle on how the vaccine works and how safe it is. But the guidance, at least in the US and I think in Canada, is that the vaccine should be given regardless of their CD4 or viral load, because the potential benefits outweigh the risks. So although, and there are other groups that weren't included in the trials who, as we heard from Kwatu, are at risk for getting COVID or higher risk than other individuals. And the guidance is that they should get the vaccine, but they should understand that there isn't a lot of data about the safety and efficacy out there.
I guess one of the questions you could ask too is, are people who are on retroviral therapy more medically stable than people who aren't? So that would be certainly a consideration, and certainly that would be something you'd want to have a discussion with medical discussion about.
Well, say more. What do you mean by medically stable?
Okay, so if you're on therapy, you're controlling your symptoms a lot better. So people who are not on retroviral therapy, I'm not sure what their status is in terms of medical stability.
Controlling symptoms. Okay, Dr. Kenty.
Yeah, I just wanted to add 2 points, and one is that none of the approved vaccines use live virus, which is one of the factors that makes it more safe for those with damaged immune systems, such as those persons with HIV who are not virally suppressed. That's number one. And the studies in the UK, which track the mortality rates of people with HIV, found that people who control their HIV did as well as the general population. It's the people with HIV who have the same underlying conditions that put all the people of African descent at risk, that were at greater risk: obesity, poorly controlled diabetes, high blood pressure. This is what put asthma, these conditions, these underlying conditions, added to the risk of people with living with HIV.
Yeah, I continue. I think I really appreciate all of you being able to speak so specifically about the vaccine trials, and then again, the science in relation to people with underlying conditions, because many people in African, Caribbean, Black populations do have underlying conditions or things that run through their family. So it's a shame that in the development of vaccines, sometimes there can be attempts to exclude people with underlying conditions, and I guess maybe in a greater desire to sort of roll out the effectiveness and not wanting to take too many factors into account. I guess I can understand that on the one hand, but on the other hand, again, it's one of those things where I think that many of us are dealing with a number of conditions, so we want to know. And I think sort of Black LGBTQ communities definitely, including, you know, sort of our transgender or gender nonconforming members, women, people just with sort of family members who identify as LGBTQ, you know, we're dealing with HIV. And, you know, we haven't really solved that. The young, gay, bi, sort of MSM who are Black are still sort of contracting HIV at really high rates. You know, we talk about sort of the HIV end game, and I know some HIV AIDS organizations have taken that as their slogan and they're working towards that. But again, as with COVID, there are not as many Black people or Black LGBT people even involved in some of those clinical trials, even with the retrovirals with HIV. And so that's continues to be an ongoing issue. So I appreciate that this panel can really speak honestly and sort of knowledgeably about how Black people have been involved in those, because that's really important for our communities to know and to gain confidence about. Okay, so let's actually, I don't know if there are other sort of technologies, or just keeping one more question about on the science tip, any technologies or any new science sort of information that you think that Black LGBTQ populations or communities or Black people in general would be really interested in to know about. There's a question here about mRNA technology and other breakthroughs. Anything else you'd like us to know related to that?
Sure. Moderna, again, they're at the point now where they've been working on 2 potential candidates for based on mRNA, 2 vaccine candidates for HIV. So they're at the point where they're getting ready to, at least they're planning to launch clinical studies with these 2 clients sometime later this year. And I just got this information yesterday. And this is very interesting because, they're looking, without getting into the details of the science, they have 2 candidates that they can actually start phase 1 clinical studies sometime later this year, which means they've done a fair amount of work already. They've probably done all the animal work. The development is fairly far along. But, the good thing about mRNA technology, even though it's a very elegant technology, but it's also it's very simple and it's very efficient. Compared to what David and myself would have seen years ago in terms of vaccine development, we're talking about very, very complex processes that take a very, very long time, and it just makes it difficult. But now there's a real opportunity to accelerate a lot of those things by the mRNA technology. So it will be interesting to see how this develops. But I would say that, for people within this community who may have a specific interest, you may want to just keep an eye on what Moderna is doing, because they clearly, the outcome of their phase 1 clinical studies will be very important in terms of the future if it does work out.
Yeah. Thank you. Okay. Maybe we could go to, Dr. Kenty started speaking some about some of the social impacts. And of course, we just got the information yesterday about another lockdown. I think everybody has a lot of strong feelings about, lockdowns and social distancing and sort of the health of our populations. I think one of the things in this most recent lockdown was the announcement that the police were going to be given additional sort of authorities to question anyone on the street and fine them up to $750 for non-compliance. As you know, there's been a really strong movement in many Black communities across Canada to abolish the police. And I think this, whether or not you agree with sort of the thrust of this activism, I think that we can all agree that it's raised a number of questions, and it's sort of pulled the curtain back on a number of practices of the police that have historically and continue to be really damaging to Black communities and lead to further incarceration. So I'm wondering about sort of these lockdowns, and do you think there's a need for this greater enforcement by the police? Fines? Do you think that this could have an adverse impact as similar to other sort of police actions? We're really aware. We're just, finishing all the trials in Minneapolis. I'm wondering what you're thinking.
I can't curse online. I can't swear online. I can't swear. I'm thinking, here we go again. Why should COVID be constructed as a criminal law and order issue? Really to mask planning failures, policy failures, implementation, operational failures, which is what it's about. So we're really in a crisis. 1/4 of the people in emergency rooms are Black people who are being moved across the province as we speak. And when you go in an emergency room, you're going to be separated from your family members. And some of the people in the emergency room need their family members to speak for them. So, they may have dementia, they may be elderly with dementia without, any of those cognitive skills. So even with family members who have their full faculties, I know for me, I want to be there with them to make sure they get the care they deserve on time in the most professional way, because of the racism that I know exists in the system. So imagine now we have a preponderant, disproportionate number of people in these emergency rooms now being moved to settings where there may not even be any Black people to begin with. So there's even less understanding and appreciation for our culture and for our needs. And just to top it off, a lot of research has demonstrated there's a limit in the empathy towards Black pain. Many doctors discount Black expressions of pain and actually don't measure it accurately or understand or appreciate it accurately, because some people will get a 7 for saying, "Oh God, I'm feeling like pain here," but a lot of people wouldn't say anything, and they're actually at 9 in terms of the pain threshold, but it doesn't get identified. So we're in a difficult situation in terms of access to care, where we are vulnerable, we are doubly vulnerable. The whole population is at risk now. COVID is uncontrolled because of the variants, and largely because 2 months ago, there should have been a lockdown. 3 months ago, there should have been a lockdown. 4 weeks ago, there should have been a lockdown, and there wasn't, and now there is. But the lockdown is being communicated in a way that, have these bells and whistles or dog whistles, underlying messages. It's not me, I'm doing my best, I got your back. It's you who's not obeying the law, you who don't listen to the law, and the law and order will bring it to you. It's potentially frightening. We've seen what happened with cannabis prohibition. We even saw what happened in the early stages of COVID, where where Black people were disproportionately ticketed for violating social distance norms across the United States. And Montreal. So it's something that we have to be vigilant about, because it's a question of minimizing harms. Now that we shouldn't have gone in that direction, and now we have to minimize the harms. And one of the ways to minimize the harms is to insist that race-based data be captured, so we can see where there's racial profiling and put a stop to it, because I expect it. So that's number one. It's a real crisis for us. We really have to sort of buckle down, because with the greater social distance, we also have to make extra effort to stay connected, because we have many people at risk from the social isolation, elderly, single mothers, a lot of people at risk, and we actually have to make a greater effort as a society to reach out to them and stay connected. I'm not aware of any specific efforts to vaccinate Black frontline workers, but we have made the argument to decision makers that all the community health workers in high positivity areas should be vaccinated, not just the people in hospitals, but people in Back Creek Health Care Center, people in Taibu Health Care Center, people who are at the front lines serving our community, who are mostly Black and racialized. They should be first in line. I also believe that all the people who work, essential workers in these communities, who cannot work from home and have to take the bus, public transit to work, should be immunized. And the way they should be immunized is that the immunization should go to them in their workplaces so that it's most accessible, least inconvenient for them. The only other piece I would add to this question is about trust. And this, one of the reason this task force has been created is because of this issue of trustworthiness, not trust, I should say, trustworthiness. Health institutions, pharmaceutical companies have not really earned the trust of Black people given the current and ongoing experiences. And so in order to get the message across and address these issues, racialized communities, not just Black communities, people in South Asian communities, Latin American communities, want to hear from people of their own background who understand the risks they're living with, what these vaccines mean for them. And that's why we were formed, and that's what we're doing. We are actually trying to address this information gap that exists in our community and being trusted emissaries, if you will, of the vaccine information.
Can I just jump in,
Yes,
Dr. McCready, on the issue of policing, and it's one that we should be really concerned about. But we saw an immediate response from most police services around the province that did say that they are not going to follow through with that order, that they would not be stopping people, they would not be putting extra effort. Whether that happens or not is yet to be determined, but they did put out statements that said that they weren't. I think one of the things that we need to really consider here, and the question in the chat, in the Q&A from Jermaine Hall, is one that's critically important when we think about the priorities of the Ontario government at this point, to not say anything about having paid sick days, but to say we are going to enforce more police action to deter people, really shows, I think it shows people the priorities of our government. And so when you ask questions about how can COVID-19 equity initiatives partner with HIV advocates, whether we're talking about HIV advocates or beyond that, I think organizations should be working together to ensure that there is that loud voice around what actually needs to be done. Remember, in April of 2020, there were decisions by two governments to collect the race-based data that Dr. Kenty is talking about. The government of Ontario at that point said no, and they still haven't. The city of Toronto said that they were going to collect it. 192 organizations wrote in. Dr. Kwame McKenzie, who's on this platform, who's on the task force, was very vocal about collection of that race-based data. We are seeing time and time again, and I don't mean to make this political, but I think we need to, time and time again, the government of Ontario making a decision that disproportionately negatively impacts our communities, or at the expense of our communities, in favor of other objectives, in favor of its friends. And so when we look at what the announcements that we had yesterday, the police forces sent out immediate responses that said they were not going to do that. But I think we as a community and people who claim to be allies need to be stepping up and talking about issues around advocacy for those who are most vulnerable, those who need it the most, people with pre-existing conditions, persons who don't have paid sick benefits, people who are don't have the luxury and the privilege of being able to drive back and forth or be, they have to take the bus, as Dr. Kenty said. So at this point, I think we need an all hands on deck approach to support especially those organizations that have already serviced vulnerable people and are seeing the negative outcomes.
I just want to just one follow-up question, then we're going to take a 5-minute break. I mean, has the province sort of consulted you? Have they consulted this committee? It's interesting. I always hear about them consulting the health ministers, and I hear a lot of who Ford and others are consulting, but I don't see y'all up there. I don't know if you're being consulted about that. Have you been consulted about any of these?
Well, 2 members of our task force sit on the scientific table, Dr. McKenzie and Dr. Upton Allen. And that science table, to its credit, has been providing fairly balanced modeling and advice. They actually have recommended to the government weeks ago, or even months ago.
I was going to say, the government's not following the science table.
They didn't receive the science table.
Well, that's true. So even if they were consulting, they are not doing what the advice of those experts have said. The reports have come out today saying the exact same thing. They are not doing that. So it really is a challenge.
Yeah, and during a pandemic, you need at least 5 days, 7 days, 10 working days, because if you test positive, somebody has to pay bills. If you're earning $14 an hour as a PSW, right? That's the average pay of a PSW, $14 an hour. That's why they have 3 jobs in normal times, right? So, and you have to know that the healthcare workers, nurses, PSWs, support workers in long-term care and residential homes, in home care, a disproportionate share of them are Black women of Jamaican and Nigerian background. And they're taking home COVID because even in the jobs, they don't get the PPE, the proper protective equipment. And not provide those sick days, that's systemic racism in action. That's a case study on systemic racism. And it's really a response to the fact that 80% of the workers are actually racialized, and 1/3 of them are Black. The rest are people from the Philippines and Latin America and South Asia. And really, their lives have less value. That's the bottom line.
And, I just might add that, there are members of Black Gay Men's Network Ontario that are also personal support workers, too. So this is a very sort of issue that's personal to our communities, too. When we come back from the break, we can talk about you sort of alluded to some of the dynamics also related to housing and Black communities. So I want to get into that a bit when we come back. But let's take a 5-minute break. And then we'll start the questioning again at approximately 3:11.
Okay, thank you.
Thank you. Okay, we're coming back. I just want to remind our audience or attendees that if you have questions or comments, I'm going to be much more guided by your questions, comments, reactions in this second half of our panel. The first part of the panel, many of the questions were generated by the co-sponsors of this event, but we also wanted to give you an opportunity to ask questions based on the things we're discussing or other stuff that you wanted to know. Just to start us off, is there anything any of our panelists wanted to add based on the conversation that we were having?
Just one quick comment.
Yes.
I'm totally missing the point of having a $750 fine to change somebody's behavior and who that's targeted at in the first place. I mean, who are we targeting by introducing something like a fine? The logic just escapes me totally. Yeah.
Can I just add to that question? Divan Miller said, what is the plan for exerting influence? So this group, this task force, is staying together over the next few months. But I think that over the last little while, what we've seen with this task force is not only at the table, but at different groups federally, provincially, and municipally, talking and being involved in conversations around having that greater influence. So hopefully that does happen. Hopefully it does translate, if not at the province, but at the City of Toronto clearly, and at the federal level. So the plan is to continue to put that influence there, and hopefully we'll start to see some of the rewards to that effort.
Yeah, I mean, if you're going to introduce regulations, new laws, then one of the first things you do is look at what the impact, do some impact assessment and see how it's going to affect all the people who are potentially going to be affected, and not the ones who are, affected in an unintended way based on not really understanding how it will affect them.
So you heard the bad news. The good news is there are many police forces that are not going to participate. Toronto has indicated it doesn't intend to participate. Peel will not be participating. Ottawa won't be participating. And I don't know who else, but I'm hoping that all of the municipalities, most of the police have municipal boards.
Durham already put out a statement, and Halton as well.
That they choose not to implement this particular policy direction.
Yes.
And that's actually because of the sensitivity towards racial profiling and the fact that it's on the agenda. Everybody is attuned to it. The trial in the US is going on. We see additional killings of Black people, young Black people, 13-year-old Black boys. And so, there's a greater sensitivity and recognition that this is a live issue.
Mm-hmm. Another sort of, in addition to, I basically talked about how there are people in sort of Black LGBTQ communities who are personal support workers that are working, I think, who may or may not sort of be open about their sort of sexuality and or gender identities in the spaces where they work. Another space that has traditionally had a lot of LGBTQ people are the arts, right? And we have a lot of members, even in Black Gay Men's network of Ontario, who are arts workers. They're gig-based oftentimes. They're not employed by large arts organizations or by theaters. They're sort of making ends meet from job to job, gig to gig. I think this pandemic obviously has had a huge impact, as so many venues have closed, so many events have been canceled. I think haven't been able to go back to work. There are many people, I think informally, we don't have a lot of this documented, some people are really turning to crystal meth and other sort of substances to try to cope with the fact of not being out of work, not having sort of their venues to do sort of what they love to do, and arguably really make the lives of all of our lives better, whether or not you identified as LGBTQ or not, right? Provide really insights about the future and what things could be. I'm wondering, what are your thoughts again about sort of how do we move forward with so many in our arts communities, our ballroom community, our sort of kiki ballroom communities? Like, you know, we're trying to move things online, but it's it's not, some of it's not enough. Yeah.
So it'll be interesting to see what the federal government puts out on Monday when they release their budget. Of course, we saw Ontario put out their budget. It was $186 billion, and there was nothing for the arts. And I keep putting these out so that people could pay attention to the priorities of your government and see where they have placed the priorities, not on the people that are most vulnerable, but on their friends. So we have an Ontario government that put out $186 billion budget. There was no conversation about arts. We'll see what happens on Monday when the federal government, when the feds put out their budget. I'm hoping to see something that is a little bit more attuned to understanding these industries that have been highly impacted, that have individuals with multiple intersecting identities as part of their economy. But this is again where, to that previous question, where we're talking about advocacy, that people need to really, especially our allies, really need to step up at this point, because we are getting impacted by sickness, by death, by a lack of an economic base, and then policing. I could keep going on, but we are getting hit so hard by this. And I think this is, if I could just close on this is why the conversation around vaccination is a critical one to have for our community. The chance to get vaccinated, and again, I'm not telling you whether to do it or not, I'm giving you information, is a powerful moment for our community. We know that we are dying. We know that we are hospitalized at the highest rate, 25%, even though we only make up 9% of the city of Toronto. 25% of us are hospitalized. That means we're dying more. This opportunity right now for Black community members is a critical one, because the power lies within us to say whether we are going to get vaccinated or not. And like you, Lance, you were saying at the beginning that you had questions. I had questions. I worked in the clinical trial industry for years, and I still have questions. I had hesitancy. After listening to some of this group speak, I'm deciding to get vaccinated. We have the power to change the outcome for our communities with our decision around COVID-19. There's a lot of things stacked against us. This is one where we can make a choice to do so. And I would hope with the information that is given around vaccines and the efficacy, et cetera, and I know there's more questions in the Q&A that I hope we can get to, but I'm hoping people will make a decision that will save our lives and save our community.
Yeah. I mean, I think that vaccinations are part of our pathway even back to our livelihoods in the arts. So obviously that's really important. It raises a bunch of questions. I think you sort of opened door for us to talk more specifically about vaccination. Again, it's pretty clear that it is going to have to be our path forward, but there are also a number of obstacles and opportunities. For instance, I live on Wellesley, right across the street from St. Jamestown. That M4X sort of postal code was designated as a high-risk neighborhood. I'm 53 years old, and so I was able to go get the vaccination. But then there were also a lot of reports this week talking about people like myself who live alone are not necessarily the target population. That what about all the folks in sort of the high rises across the street For me, I mean, my building has 12 floors in it, but I guess the high rise, like, 20 something floors or 30 floors in it. There were not a lot of, I think there were a couple, I saw mobile clinics that were set up in St. Jamestown, but, not necessarily a huge presence. And so there's a lot of, this weekend, there was a lot of news reports that even though they had identified high-risk areas, that the people in those high-risk areas that were most at risk for COVID were not getting vaccinated, did not have sort of access for various reasons, either because of pre-existing conditions, because it wasn't as accessible, they had to sort of go downtown to some place that, they might have had difficulty going to. So I think there are a lot of, and I should also say that Black LGBT communities, most of us are not homeowners. Probably the majority of us, we don't know this, but we don't live alone. I do. I have a good salary as a professor and can afford me living alone, or with a partner. But we are living sort of socially with sort of multiple people to make rent due in this expensive city. There are sort of fewer and fewer places where we can live, and many of us are living in some of these Northwest communities also that we talked about, or Northeast communities. We're because of stigma, many of us are not really scared to be more visible, but we're there. We're in those communities. We're in sort of, we're facing a lot of barriers in terms of even getting vaccinated, and the vaccinations, there being enough vaccinations. So I'm wondering if the panel could comment on that. Some of it has to do with hesitancy. That's why I'll say, my aunt sent me a text, she said, Lance, do not get the AstraZeneca vaccine. It causes blood clots. I thought that was a little dramatic, and I thought, okay, Auntie, I appreciate your concern for me, but I actually don't think the majority of the issues are about hesitancy. I think there are a lot of sort of structural barriers that are leading. It's not like an attitude or a cultural thing, only there's just Black people are concerned about it. There are real structural issues that we're facing, and specifically even in Black LGBT communities. Another one, I'll just bring up one other one, has to do with immigration status. Like, what if you don't have status, or you're on your way to getting status, and sort of the access to healthcare and sort of vaccines, and you're wondering, what being undocumented, if, you'll be unnecessarily targeted. So could we talk about some of those sort of structural barriers that really intersect in many of our multiple social identities to make it difficult for us to access vaccines? Any sort of ways forward that you can give us would be really helpful and be part of the conversation.
Maybe I can comment on the last part of your comment when you mentioned people who are undocumented. I was on a panel a few weeks ago with someone from Toronto Public Health, and they actually said, and it's true, that it's, if you haven't got a health card, you can't register online for a vaccine. And frankly, even if you've got a health card, I mean, it's I think the system is crazy because every district seems to have a different way of logging on and accessing the sites that they have. So I think there's a lot to be desired, and there's a lot of improvement that could be made. But for individuals who aren't documented, this person from Toronto Public Health said, phone Toronto Public Health because they're not refusing anyone vaccine. So, and they're not going to be, they're going to respect your privacy. They're not going to out anyone if they're not documented, if they're illegal. If you need a vaccine and you haven't got papers or card, phone Toronto Public Health and they will assist you and help you and direct you to where you can get the vaccine.
I just put the number in the chat. I just put the number that you could call in the chat.
Okay, can I add to that? Because I was a bit curious about the question about anonymity. And the point is, if you have a 2-dose vaccine, then, you're going to have a way of following up on that. So it needs to be clear that there is that possibility. If you can get an initial vaccination, and you can be available to get the follow-up, because it may, depending on your situation, you may need that second dose.
Mm-hmm.
Yeah, if I could add, I would just add that Toronto is a sanctuary city. Unfortunately, some of the mass immunization sites you require provincial registration, but the mobile clinics, the pop-up clinics, don't. And best advice right now is to go to one of the mobile clinics, and the ID that's required really is not the OHIP card; it's a basic ID, and it's for the purpose that Trevor spoke about, really. Second dose. Also, if there's problems with the dosage, if you get any allergic reactions, not within the 15 minutes, but later, they need to be able to track that and include that in the national data around vaccine adverse events. So that's point number one. We live in a city that's a sanctuary city, and legally, you can expect to be able to get that vaccine without having to prove or provide proof of citizenship, and it shouldn't matter. So that's number one. Number two is that leaders in the GBMSM communities have to be mobilized for this effort, for the vaccination effort. I know you mentioned that many establishments have been closed during COVID because of the economic downturn and the high cost of the social the measures, but in truth and in fact, the best approach to get this vulnerable community fully vaccinated is to use those very establishments and safe places where people are comfortable, they're themselves, to do the vaccination. And there are various ethno-specific and other networks of GBMSM that I think should be mobilized, along with the network of AIDS civic organizations throughout the GTA that are also connected to those networks. I know also there's a network of clinics and other healthcare professionals whose clientele includes large numbers of GBMSM, sorry for the acronym, and they also need to be part of this effort, this solution. And the problem is the centralized approach isn't working. It should all be according to risk management, and where the people can be accessed and where people feel comfortable going to get the vaccine. And if they come comfortable going to faith locations, churches, mosques, what have you, they get the vaccine there. But if they come more comfortable going to community centers where they frequent, give them the vaccine there. The idea is to save lives, reduce hospitalization, reduce positivity in the way that's most accessible for people. And that's actually enshrined in disciplinary practice of public health. So I'm not inventing this, I'm not creating this. The literature and the best evidence base says this is the only way to do this right. You don't have to create anything new. You have to just respect the human rights of all of the persons involved in the communities at risk. And that I actually want to...
Where would we lobby, or who would we lobby to? For instance, what if we wanted to set up a vaccine clinic at Black Coalition for AIDS Prevention, or what if we wanted to set it up at, here, one in St. Jamestown Health Center? What if we wanted to set it up there, like in all the other...
Talk to Toronto Public Health. Request it from Toronto Public Health. But they don't control the vaccines. The province are the ones who controls the vaccines. But there's a registry for the mobile and the pop-up clinics. Mm-hmm. And I actually, we're hoping to have a Black vaccination day on May 8th. So we actually registered for to have a mobile clinic up at the JCA, because the idea is to sort of create a different cultural vibe around vaccination. If you go to, I've been vaccinated, and I took my mom to get vaccinated in Ajax. And it's a pretty somber affair. You feel like you're going to a funeral, everybody quiet, separated, you know, and, you know, it doesn't have to be like that. You know, I want to have a DJ in the background, some, you know, access.
Well, look, we could have a fabulous vaccine clinic, but I guess we need to know that we can actually, you know, set up a pop-up clinic where we know that sort of gay, bi.
Absolutely.
You know,
and I'm telling you, yeah, absolutely.
Good. I mean, we definitely have the resources to sort of create sort of something that's engaging where folks will want to do. And I think that people in our communities that would be ready to sort of sign on to do that. But, you know, one other issue, just we'll probably come back to the structural barriers, but I guess we should just ask flat out to our science table, is one vaccine better than the other? Does it matter if it's, you know, AstraZeneca or Moderna or Pfizer? Is there anything to be concerned about sort of with those reports? You know, I remember from my own graduation, on the way back from graduation, my father got a blood clot on the plane and had to be sort of hospitalized. So I'm very sensitive to that, but I'm wondering, please tell us, Black Scientists Taskforce.
Go on, Trevor, you can start, Trevor.
Okay, so first of all, let me say this. Between the Pfizer and the Moderna vaccines, there isn't really any significant difference. They're basically the same. The formulations are slightly different. Some of the ingredients are a little bit different from one to the other, but generally they're the same. It's the mRNA. It's got some lipids and some liquid conjugates that's used to form the lipid nanoparticle. It has some phosphate buffers in it to buffer it. It has some sucrose to stabilize it, and a few other things. But you know, other than that, they're roughly the same. And in terms of the efficacies are, for all practical purposes, the same. However, efficacy is not, as the way most people look at it, is not necessarily the best measure of whether one vaccine is better than the other. Because the reason for that is that, you know, we all know that in the case of Pfizer and Moderna did their clinical study in the last summer in the US. Pfizer did theirs in, most of the participants were in the US, a few were in I think Germany and somewhere else. But there were a very, very small number outside of the US. Now, people are comparing those two with AstraZeneca and Johnson & Johnson. Those studies were done a little later in the year, closer to the fall, end of the year, but they were done in different locations. Those studies were done in, you know, for example, one was done where a lot of the participants were in South Africa. And so in those two second studies, they were seeing a lot of the newer variants when those studies were performed. So it's not a head-to-head comparison. There's no way you can imagine that you're comparing those four vaccines by just looking at the efficacy data. That is not what it is. So clearly, in the case of AstraZeneca and J&J, the efficacy data is showing you that how the vaccines were responding to the newer variants. In the case of Moderna and Pfizer, the clinical study was responding to the original strain, although both Moderna and Pfizer have data that shows that their vaccine have efficacy against some of the newer variants as well. But it's not as clean a picture as, you know, just looking at a few numbers and trying to come up with an answer. So as far as I can tell, all the vaccines are efficacious and they're doing what their ultimate goal is, and that is to prevent serious health injury and, most importantly, to prevent death. So that's really the best way of looking at it. However, I mean, there are some other factors that are clearly coming into play now, and that is, what is the impact of the fact that we're seeing a few rare incidences of blood clots from, say, AstraZeneca. And there's a report on J&J as well, but I'm not sure if they've concluded yet whether that's real or not. They had at least a couple of incidents of blood clot formations. But you know, it's really hard to come out flat out and say one is better than the other. If you're not at a risk for say fall into a risk group for, say, blood clot formation, it probably doesn't matter as much. But then again, that's become a little bit more clouded now because there's at least one data point from Quebec that says, well, you know, that there's one person outside of the normal group that we want to exclude from this time for that vaccine. But, you know, it's not crystal clear in terms of whether there's any significant differences.
Yeah, and just to add to what Trevor's saying, really the most important thing that we need to take home, the most important message is that all of these vaccines will protect you against severe COVID, hospitalization and death. And that's even for the case of the variants that we have at the moment. It might change in the future depending on what the variant is. But the most important fact is that any of these vaccines will protect you from severe COVID, hospitalization, and ultimately death. So whichever vaccine is available should be the one that you take. Now, we always talk about AstraZeneca, but I think Lance mentioned blood clots that you can get when you're on an airplane flight. And actually the risk of getting a blood clot from AstraZeneca is about the same as the risk of getting a blood clot on an airplane. And we most of us will take that risk, right? Because we want to travel. And the risks, the severe adverse events for AstraZeneca type of vaccine and for the mRNAs are very rare. The risk is very rare. We're talking about a few cases in a million. And so we have to balance that with the risk of getting COVID. And if you look at the data in the United States, it's shocking, but one in 500 individuals in the United States have died of COVID. You know, more than 500,000 people have died of COVID. And the risk, the benefits totally outweigh the risks. And that's the message for all of the vaccines. And really that should be the message that we're promoting, because really vaccination is the only way we're going to get back to some semblance of normality in our society. And the quicker we are vaccinated, the quicker we get to this herd immunity. And I think someone was asking about the herd immunity, but you know, if 70 to 90% of individuals are vaccinated, maybe we can get back to some sort of degree of normality.
Any other thoughts about?
Okay. I think there's a question there about what's in the vaccine, David.
Yeah, there is a question, and we talked about that a little bit. You know, okay, going back, I guess we're going back between the social and the science and the medical science, because there is a question also here about like, I had a very bad reaction, and I've also heard some of my friends have had, and a couple of family members have had bad reactions to that, meaning, and when I say that, I say they felt very sick, or they did not feel well for a couple of days, or they were sort of, you know, very fatigued, tired, had flu-like symptoms. Like that's what I mean when I say like had a bad reaction. How do we make sense of this? Does that mean you needed a second dose? Does it mean if something bad happened, the fact that you're having a bad reaction? Could you say a little bit about that? Actually,
often that means your immune system is kicking in and doing its job. I'm sure most of us have had other vaccines like the influenza vaccine, and many of us have already had the COVID vaccine. And a normal reaction is often pain at the site of the injection, a bit of fever. I mean, I had a headache for a few hours. I took Tylenol and it was gone. And actually, most people are going to get some type of reaction. Usually it gets a bit worse after the second dose. But again, the immune system is recognizing something that's foreign, and it's generating a response. It's like an inflammatory response. generates heat, and so it's often a good thing that you're getting these symptoms, because it tells you that something's going on. Mm-hmm. And as you said, usually it dissipates after a few days anyway. So these aren't serious events. I mean, an anaphylactic response, an allergic response can be a serious event. And there's something in the mRNA vaccines like Moderna and Pfizer, polyethylene glycol. It's a sort of stabilizer that seems to be the component that people are allergic to. But actually, this isn't a rare substance. It's found in fact, if you look at liquid Tylenol, some formulations, it's in liquid Tylenol, it's in laxatives, it's in some creams. So there might be individuals who've had some sort of allergic response, but again, that could be treated on the spot. That's why we have to hang around for 15 or 30 minutes after the vaccination. So but it's even rare. So even those rare responses for those vaccines can be treated. Now the clotting is another issue, but thank goodness it's a rare one. And there, I think the clinicians are working out ways to treat that. But these are rare events. The most common side effects we'll get, but these can be dissipated. These will go in a few days. And, I like to tell people the immune system's working. So, your body's reacting and trying to respond to what's happening to you.
So what you're speaking of, Dr. Bert, you're not really speaking of sort of long-term effects. These are really like short-term effects that some people have had. There have been, so far, we don't really know anything about sort of long-term effects or risks of the vaccine, right? We were discussing that earlier, that we really don't have a lot of data on that yet. But right now, really, the benefits far outweigh the risks. And even across the different vaccines. I mean, I wonder, we have approximately 15 minutes left. Also, I'm thinking a lot about recovery from sort of the pandemic. I was also part of writing a brief for the Science Table about the impact on education and schooling. For children and youth there, I don't know if you want to use the term learning loss, but I'll put it like this. There's a lot of missed school. There's a lot of sort of missed content and stuff for many of us that we're dealing with. I think there are long-term sort of mental health issues. There are long-term physical issues with even being able to, Dr. Todd, I really appreciated your comments about, getting outside, getting some sun, getting some exercise, trying to eat well. It's, as we know, it's harder to eat well when you have less money coming in, or if you're not making a salary. It's hard to sort of think of creative ways, and then sort of getting outside if there's this threat of police, and also if you just have fewer options about where and how to walk around. So I also think that, I guess immediately we have to think about sort of vaccination and getting as many people in Black communities vaccinated, but I also think we need to look ahead to recovery and what we're going to be doing about that. Do you have any sort of thoughts about sort of moving forward with that, recovery from the pandemic? Really love to hear if you have any sort of further thoughts, Dr. Todd, about that.
Sure. Sorry. So we are, and I already see it now in my practice, we're in for this huge wave of mental health concerns. So I'm already seeing so many people who are experiencing anxiety. They don't understand potentially what the anxiety is. So, they're maybe having physical manifestations, or having palpitations, or having digestive issues. They sort of can't cope with day-to-day life. And, depression is a huge one. We've been, again, inside. I'm a huge advocate, obviously, of getting outside. I know it's difficult in these circumstances, but being inside affects us greatly internally. So in terms of vitamin D, for example, and deficiency. So we are in it, and we're in for this huge wave of PTSD, depression, anxiety, all these mental health issues. And now more than ever is the time to take that stigma out of mental health, seeking help for mental health concerns, and even identifying with a mental health issue. So there are a number of, a huge increase in terms of therapists available out there for you, therapists who look like you, therapists who, identify with some of the things that you identify with as well. So take advantage of those resources that are out there. Social connections is a huge one. I know sometimes in the midst of all of this, we can feel so alone, especially when we have to self-isolate and distance and essentially be away from people. But, even digitally, virtually, maintaining those social connections is huge. And again, doing those sort of self-care things for yourself to support your own mental health, support your own overall health. That includes sleep. I'm a huge advocate for sleep as well. I actually recently was diagnosed with COVID. I had COVID a couple weeks ago, and I slept for the majority of the week that I was going through it. So thankfully my case wasn't terrible, but along with that, I struggled with, I need to make an income, I need to go to work, but then there's that potential of what is the impact on my patients? So, there's a lot of things that we're struggling with right now. And it's really important, I think, to take advantage of the resources out there, and, connect with people, do all those things to support your mental health.
Anyone like to add to that? Thank you so much.
If others aren't ready to jump in, this pandemic has created a huge potential education gap, and it will show up where it's least desired in terms of low-income communities. The PTSD, we can see it coming, it's happening in other places. But we've also experienced significant setbacks in savings and wealth being used up over the year repeatedly. You lose the work. So we actually have to really think our way during the pandemic to be positioned before we get post-pandemic. Otherwise, when post-pandemic, we're going to be more vulnerable than we were going into the pandemic in terms of stigma. So that, the silver lining in the cloud really is we have to use this opportunity to dispel stigma about mental health, but also about how to deal with mental health. We have a lot of potential mental health resources in our communities. Our faith leaders, spiritual leaders could be a real mental health resource, if we were determined to use them that way. I did a project in Haiti where we used voodoo priests. We actually taught voodoo priests cognitive behavior therapy interventions. We adapted it because, the people they worked with weren't literate. So homework, the idea of written homework didn't work, and we had to use creative dance, music instead of homework to sort of replicate the purpose of the homework. But it worked, and we were able to reduce depression in this very under-resourced setting. So we need to be thinking outside the box. How do we address the anticipated mental health needs? The good thing is we had mental health problems going into this COVID situation that were unaddressed. So here's an opportunity to address it and to reduce the stigma. Because of the educational gaps and the fact that some people will be 2 years older, there's a whole issue of trades that we keep skirting around because our kids get directed into these programs they don't want to be in, well, here's an opportunity. There's some well-paying jobs that we can't even apply for because we don't have the skill sets. And maybe we really need to sort of gear up to get those occupational bearings. And then there's the home ownership issue, because we have a significant segment of our low-income population stuck in concentrated poverty, where generation after generation, it's now become an intergenerational experience. And we really have to address that as a community. And I think here's the opportunity to do so through a national housing type initiative. And of course, finally, basic income. Basic income. That $14 an hour PSW salary with 3 children, 4 children to support, elders to support, means that you're going to have to be doing 2 and 3 jobs just to cover some of the most basic expenses of living. And do we want to go back into that level of vulnerability for anyone? No, I don't think so. So I think the time for basic income is here. We had a pilot, it was working, it was stopped, but we need a basic income as much as anybody else.
Yeah, and I think that's especially important, again, for members of Black, gay, bi communities, LGBTQ communities, especially our young people, many of whom, because of stigma and the gender-based violence and harassment they face in their homes, have to live and have to leave those homes for their own sort of well-being. And many of us have to live collectively in order to then survive. I think we need many more strategies of collectively how we're going to address housing. And I don't know what kind of programs or ways to figure our way through that. But I think a lot of it probably hasn't been even thought of yet, but I know that that's a real issue. We're not even talking about individually being able to make a salary anytime soon, being able to own a home in the GTA. So the only way forward, really, if some of that is going to have to be collectively. I also think that we have a wealth of talent within the arts and other sorts of arts media within Black LGBTQ communities. How can we harness that to really do more mental health work? Not always, Marlon Bailey called it develop interventions that come within our communities that sort of build on our talents and our sort of our culture, our sort of social networks to really sort of challenge that, rather than always having to go through the ways of validating through program science, whether or not an intervention works, or even adapting ones that have been proven to work with other mental health interventions with other non-Black populations. So I think that's one of the things we really have to think of, developing these interventions and ways within Black LGBT communities where we have a lot of strengths. We have a lot of sort of non-monetary resources. We just need sometimes the monetary resources to jumpstart them and get them. I want to also, there's a question here that had to be reposted, really going back to something we were discussing before. Is there an answer? Why isn't HIV on the list of pre-existing conditions for getting a COVID vaccine? Many people in our communities are living with HIV. We're continually trying to get folks tested and get them into some sort of care continuum, get hooked up. Why isn't HIV on the list of pre-existing conditions for a COVID vaccine? Isn't that unfairly creating a barrier for those of us in our community who are HIV positive that need to get vaccinated to protect ourselves?
I don't know the answer to that, but I do know that one of the takeaways going forward is that there's a consensus actually that all people who are living with HIV should be given access to the vaccines as a priority. And this is especially important because Black people bear this grossly disproportionate share of HIV infection in Canada, similar to what we know with respect to COVID in Toronto, Ontario. So definitely it should be a priority, and it should be included. So that conceivably could be one of the recommendations we make going forward.
Yeah. I mean, is that because you think because there's still an issue of talking about HIV openly and the stigma of that in Black communities that we can't, that's one of the issues?
I think the main reason is probably that the antiretroviral drugs, if you take them and if you take them and the way they're supposed to be taken, you have the same risk as anybody else in the population. But what got lost in translation or wasn't factored in was these underlying conditions which make Black people at risk, people of African descent at risk, also make people of African descent with HIV at greater risk. And that needs to be raised as an issue.
Mm-hmm.
So if you got diabetes, asthma, high blood pressure, heart disease, together with HIV, your risk, your mortality risk are amplified.
Thank you.
That's the UK data. I mean, the UK data supports that position very well.
Okay, so we're almost at time. I want to give any of our panels, all of you, an opportunity to give any sort of closing statements or thoughts. I think we really appreciate you coming to speak directly to Black, gay, bi, MSM, non-binary, trans, and all of our sort of gender and sexuality diversity, speak directly to us about, COVID, the pandemic, vaccine, barriers, the opportunities, the science of it all, because we don't often get this opportunity. And I think, again, I was saying, many of us are dealing with the kinds of stigma that makes it difficult for us to sort of be more public. And so we appreciate the opportunity to do this. But any final thoughts, things you'd like to say first?
I think there was a comment on the chat at the beginning where someone said, well, why should we trust the vaccines after what we've been through, after the inequities? And I understand that's a really important question. And it's obviously in the minds of a lot of people in our community. And we have to recognize that, it's been an issue in the past in terms of inequities, withholding life-saving medicines from our community. And it's an issue in another form, in other forms today, in terms of access. But I would hope that in this situation that we're in its pandemic, that we sort of look at what's happening. Almost over 8 million doses of vaccine have been administered in Canada alone. In the world, nearly 500 million doses have been given. And we know generally they're safe. So there's that aspect. I think we can sort of trust, after so many people have been given the vaccine, that it's worth taking and the benefits are there. And also, Black doctors have been involved in developing and testing these vaccines. I mentioned, probably not today, but one of the reasons we have the Moderna vaccine is because of the work of Kizzy Corbett in the United States. She actually developed the way to actually give the protein, the S protein we talked about, in a form that could be used as a vaccine. Her studies were excellent. She's paved the way. She's a scientist, a Black scientist, but in the evenings, she's advocating, she's telling people, take this vaccine. I've worked on it, I trust it. And I hope that our community can understand that, we have people who are like us, who have worked in the vaccine development, these particular vaccines, and we can trust them because they they know what's in the vaccine, and we should trust them more than we trust what we, often some of these messages on social media. So that's my message. People like us have worked on these vaccines in developing and testing, and believe in them and trust them. So that's my message to that community.
Okay. Can I just quickly add, first of all, I just want to say that Kizzy Corbett is an amazing young woman. She's actually very young. I think she's only about 34, but she's done some incredible work in her time. But I just want to add a little bit to what David's saying, the vaccine development process. So for people like myself, it's a continuum. We're looking at vaccines from the very early stages all the way through to commercialization and post-commercialization. So people like myself take a very hard look at vaccine quality all the way through the process, and it's a very, very rigorous process. I know some people quite often bring the question up about these vaccines were developed too quickly, so I'm going to wait. Well, the question is, what are you waiting for? If the evidence is there that they're safe and effective, the only thing you're waiting for is additional real-time data. And as David said, quite a few 100 million doses that have been distributed already. But I look very closely at the entire process, and I particularly, certainly, I'm semi-retired, but when I was working for my old company, which is a vaccine company, we spent a lot of time making sure that everything is the requirements. And the regulators also do that, because before you can even inject a vaccine into a human, you have to have done enough studies to support being able to do that first phase 1 study. So you've already done all your animal studies, the formulation of your vaccines, you've done a lot to do that. You've validated all your processes, and all your testing methodologies have to be standard. And on top of that, all of these vaccines are sterile injectable drugs, and there's a huge standard required for sterile injectable drugs in the first place. So there's a lot in place. And if you look at the requirements that agencies set out for along the process for before you can even start doing clinical studies, you have to go an IND application, and the burden is very high of being able to demonstrate safety before you can actually start an investigation in the drug process. So there's a lot built into the process. So it's for people who have hesitancy. Even though some things were done, appear to have been done very quickly, there's a lot that had already been done, and David can talk about that. So there's a lot of built-in assurances along the entire process. And when you make any drug product, whether it's a vaccine or not, you have to be prepared to support it all the way through. And we talk about phase 4, which is post-commercialization. You're looking at that vaccine very closely in the marketplace. So there will be a lot of additional real-time data that will be accumulated over the next little while. And we all can remind ourselves that currently the vaccines are approved for emergency use. So they're not approved licensed products yet, but so there's a lot of real-time data that's yet to be collected to get those final steps completed. So, but there's really good data to support these vaccines right now.
Well, thank you very much. I think that we've learned a lot today about sort of the science of vaccination and the manufacturing of them. And we really appreciate that. And I think that we can sort of take that to have a much more quote unquote trust in the vaccines themselves and the benefits of them. Though, of course, we are still dealing with so many of the social barriers. And I think that's really, and access issues. And I think that's really equally, if not at this point, more overtaking us. So our Black communities is really getting access to vaccines, regardless of which one. And so you've given us some excellent ideas. We've also had some excellent discussion about sort of recovery and naturopathic approaches to really just boosting and keeping our immune system healthy. So I want to thank all of our panelists, Dr. Kwatu Tenti, Dr. David Bert, Dr. Trevor Aldridge, Dr. Candice Todd for taking time on a Saturday afternoon and speaking to us. We're going to